So hi everybody, it's a great pleasure to be speaking to you today around World Bipolar Day, which of course itself is tied to Van Gogh's birthday. Um, One of my favourite artists. I normally in my talks actually pull some of his images, but in this particular one, I'm using a slightly different sort of look to the presentation. What I'm going to be talking about over the next 15 minutes or so is just really a headline summary of what we know about self-management in bipolar disorder. I hope you'll find it interesting. The ideas we're presenting have emerged from research and practice that we've been doing over the last 10 or 15 years probably. Um, and so if you're someone with bipolar disorder or a carer, you'll recognize a lot of these things. But I think the way that we've organized this information is quite useful. I should introduce myself first, perhaps. I'm not sure if that's going to be tagged onto the video at another time. My name's Greg Murray. I'm a clinical psychologist and director of a research centre at Swinburne University in Australia. I'm just going to share my screen now, and you should now be seeing the slides that say self-management to stay well with bipolar disorder. We've got 7 tips, and each of these tips emerged originally from a study that we did, as I say, something like 10 or 15 years ago now, where we contacted people who self-described as living well with their bipolar disorder. And we went to them and said, how do you achieve that? And subsequently, we've gone and sort of validated those outcomes in different populations. The original data were collected in Canada. We've seen very similar things in Australia. Susan Russell is a researcher who did a very similar study here in Australia, which completely independently, and we checked her findings against ours and they meshed up. But then, of course, we've had the opportunity to present these sorts of ideas in many different contexts, myself as a clinician, to the people I supervise, and to sort of more public groups like this. And we always get the feedback that, yes, those things really do matter. And this is number one. Bipolar disorder is one of those conditions where, like most mental health conditions, but perhaps particularly it's got its own features, but there's sometimes some stigma attached to mental health conditions, which of course we're all trying to knock down because it's silly and it's not useful, but there is some stigma around it. And part of the problem that goes with the stigma is people often don't think through exactly what they mean by bipolar disorder, and they aren't necessarily clear on what what the facts are about bipolar disorder. And that's a problem if you have the condition, because it makes it harder for you to talk to people about it, both your clinicians, your family members, and your friends, and even your employer. And I know that there are real issues about what you share with your employer about diagnoses, etc. But it's very clear from people who live well with the disorder, they say one of the very first things that they want to share with the broader bipolar community is make sure you know about the disorder, what it is, what it isn't. It's not schizophrenia. It's not a personality disorder. It is chronic and relapsing typically. Most people deal with the problem in an ongoing way and have to be careful about relapse. And here you'll see on the slides, the way I've organized today's talk is not in terms of a list of facts, but I've actually framed these things as questions for you to think about. So in relationship to the issue of being knowledgeable about the disorder and educating others, I think these are the 2 key questions you should think about for yourself, and that might take you on a bit of a journey of learning. Question 1, what's the most important thing you think people need to know if they've just been diagnosed with bipolar disorder. So think of yourself as an educator. What would you be instructing people that they need to know about the disorder? I'm thinking things like medication. I'm thinking things about, causes of bipolar disorder. Is it genetic? Is it through trauma or life experience? Spoiler alert, it's due to the interaction between genes and life experience. Um, what are the treatments? Medication, psychological treatment. Spoiler alert, the best treatment for bipolar disorder is a combination of medication and psychological treatment. And if you're not getting both those things, you should look into it. And then question two that I'd want you to ask yourself is, what is the most important thing others need to know about bipolar disorder? So from your experience, what's the big misunderstandings? What's the key things that people need to know so they can be helpful for someone with bipolar disorder? I'm thinking there about, sometimes we ask family members and carers to play the role of observing symptoms, for example. But how do they do that? And how do they communicate those observations back to the person with bipolar disorder? They're the sorts of um, stimuli, those questions, that I think are useful to start to think about. Now, as I say, this is a very brief overview, and I'd love to, we could obviously speak about this for a day. But these are just headline news. Let's move on to the next one. The other thing that people tell us really matters in terms of self-managing bipolar disorder is having a concrete plan to respond if you are seeing any signs that you're sliding into another episode. So the question you should ask yourself is, do you have a plan? And is the plan written down? Is the plan shared with other people? If it's shared with other people, do they actually know what's expected of them? Have you thought through, if you're someone living with bipolar disorder, have you thought through, oh, when I'm in the mood state where my plan might need to be activated, am I actually going to be able to follow through with the plan? For example, one of my clients taught me this. She said, oh, I used to have this plan where if I was sliding into depression and perhaps I was having suicidal thoughts, the plan was I was going to contact my sister because she's a great support. The plan didn't work because when I'm sliding into depression and having suicidal thoughts, along with those thoughts comes the idea, I don't want to bother my sister. She's very important. She's got the kids, she's got the job. I don't want to bother her. So that plan needed refinement because it actually didn't work. So the first thought about what the plan was, it hadn't gone, you hadn't sort of projected into the future and thought, actually, how will this work? And that's where it's very useful sometimes for people with these plans to actually talk to others they imagine are involved in the plan, like a clinician, like a family member, have that discussion to confirm, yes, this would actually work. They are happy to play that role, and I'm happy asking them to play that role when I'm in that mood state, not now when I'm euthymic or, things are going okay. Next point, ongoing monitoring. Standard practice from a clinical viewpoint, if you're a psychiatrist or psychologist working with someone with bipolar disorder, one of the first things that we will make sure is in place is monitoring of your condition. But what I've found over the years is many clinicians aren't that thoughtful about that recommendation. So they might say, okay, so I want you to monitor your mood. And obviously the logic of that is that, if we monitor mood closely, say on a daily basis, then theoretically you're going to notice changes in your mood. And if you're starting to get a bit excited or hyper, you'll notice that, and we can institute early intervention. Perhaps you'll have an appointment with your professional, for example, or sliding down into depression. Again, you'll notice it. You won't sort of keep sliding. You'll do something about it, right? So it makes perfect sense logically. But the details of it, we've noticed that sometimes clinicians aren't very helpful in getting people, A, to do this, and B, exactly what does it involve? So what I mean by getting people to do it or encouraging or supporting people to do it, they actually haven't thought through, well, what's difficult about monitoring your mood, for example, daily? And of course, it's easy to think of things that are very difficult about that. Firstly, I don't necessarily want to be reminded every day that I have bipolar disorder or, an ongoing chronic mood disorder. If things are going okay for me, I would prefer my bipolar disorder to recede. I don't want to get up every morning and make a report, no matter how easy it is to do that. And I'm not saying everyone feels that way. Some people, the daily monitoring makes them feel much more empowered and in control of their disorder. But a subset of people, we can understand why they may not want to do it. So we want to unpack with people the pros and cons of monitoring, the challenges of monitoring. And then the other thing that's really important is it's not necessarily mood that's the most important thing to monitor. Theoretically, it is. This is a mood disorder. There are symptoms. Monitor your symptoms, right? But it may not be the best thing for you to monitor. So again, my clients have taught me, quite a few clients, the signs that they might be getting a bit hypomanic are not so much to do with noticing mood changes, but noticing, for example, that they're speaking more quickly, or that people are saying you're speaking loudly, or saying, "Excuse me, you just interrupted me." Or one of my clients, what they were monitoring was the vividness of colors or their emotional response to music. These were part of that particular client's what we call relapse signature for mania, hypomania. Nothing to do with mood. So to ask her, how's your mood today, was not informative. But to ask her, how bright are the colors in your bedroom today, was very informative. And people have similar things for depression. And I'm just encouraging you to think through, what would that be? It may be mood, but it may not be. The other thing that's I think, again, clinicians may forget and may not remind you of, and this is why, this whole talk is about self-management, things that maybe patients know better than clinicians do, is the importance of relationships. And there are a couple of questions that I think get to the heart of that for you if you have bipolar disorder. And they are these. What makes someone a good support for a person with bipolar disorder? What in your experience helps you determine who you want to loop in? Obviously, generally connecting with family and friends, that's just a good thing. That's important. But in the context of bipolar disorder, who might you lean on? Who would you seek out? And so I want you to think through, for you personally, it'll be different for different people. What makes someone a good support? What are you expecting to get? What's good to get from people? Um, Around your bipolar disorder. And I'm just conscious here, saying what's good to get. Obviously, all relationships are reciprocal, aren't they? And so, yes, we do want to get things from our supports, but also one of the most satisfying and grounding things that can happen in life is, of course, giving things to people. So, just your bipolar disorder doesn't necessarily get in the way of, well, in fact, of course, it doesn't get in the way of you being a great supporter for your family and friends. So we just need to think about both sides of that equation to get the whole story, don't we? Um, and you might also want to think about what makes someone not so good as a supporter. What doesn't work? Someone might be really, really good around, your career or your relationships or talking about the footy. By the way, go Carlton. It's the first game of the AFL season today, and yeah, I'm pretty focused on that. So someone might be great for talking about the footy, but not so great for talking about mood problems. And then finally, just to think about, yes, relationships generally are good for human beings, but we all differ on how we want relationships set up. And that's perhaps particularly the case for people whose moods and motivations vary. So just have a think about and make sure you're being kind to yourself about how you relate to other people, like how much contact you want to have. And remember that it's okay for the amount of contact that you want to have to wax and wane, but maybe you want to explain that to people. Key to the sort of causes of bipolar disorder is something that most people are familiar with, and that's sleep. Everyone who with the diagnosis of a mood disorder probably knows this. Something that people aren't so familiar with, and I'd love to talk to you more about this because the story is a bit tricky, but fascinating, is the role of daily routines. And what we mean by that is making sure that the time of day that you do things that happen across days stays about the same. The key ones in that, key behaviors that we all do every day, include getting up and going to bed. But other behaviors include mealtime, socializing, exercise. Those sort of things are what we call daily routines because they happen every day. The important thing is to make those things as stable across 7 days of the week as you possibly can. That has mood benefits through the body clock, but it also helps improve sleep. Little bit of a complicated story about biology and behavior underpins that. And I can direct you to stuff to read if you want. But yeah, take it from me. Daily routines matter and they support sleep. One of the things that we were happy and a little bit surprised to see when we conducted this research originally was that many people told us that a key part of staying well with bipolar disorder was some form of reflective or meditative practice, yoga, active relaxation, the flow states that some people get into when they're listening to music or engaging with art. Um, and I suppose we just put this here because many people already have it in place, but we really want to validate it as an important, the way I think about these things is they can be very grounding for people, especially if they're done in a routine way across multiple days. And I just want to validate this. If you've got one of these in place, if you haven't got one of these in place, we think it's probably worth you exploring to find one that works for you. And then a key sort of more medical thing, if you like, is making sure that the clinicians you work with talk in a way that you like, and you can express yourself in a way that you're comfortable with those clinicians. And that might involve a bit of trial and error, finding the clinicians that work for you. But it does involve, as we said right at the start, making sure you're knowledgeable about bipolar disorder so you can communicate to them about what's going on for you in a language they understand. But you also want to be able to, of course, to express yourself in your own terms, in more personal terms, in your own preferred style, as well as being able to speak the clinician's language. And then there's a further little complexity about this that we're really conscious of now. Many people with bipolar disorder have multiple clinicians. And in Australia, at least, there is in what we call primary care, outside the hospital environment, you might have a GP, you might have a psychologist, you might have a psychiatrist. We are conscious of the fact that that relationship between those three professionals may not be optimal. They may not know each other. They may not talk to each other very well or very regularly. And I suppose while we're working on that, that's actually something we're doing at the national level, trying to get that better. But while we're working on that, we want clients to know that they are actually in a position. Just be conscious of the fact that just because you've told your psychiatrist doesn't mean your psychologist knows, or just because your psychiatrist has made, say, a change to your medication, that doesn't mean your psychologist knows. And you might want to take responsibility for either checking. So you say to your psychiatrist, are you going to share that with my GP and my psychologist? How will you share that? Are you going to send a letter? Are you going to make a phone call? Or do you want me to tell them? Right? So I suppose the thing is, the person with the disorder is at the center of their own management. And that might include helping the professionals do their job, that aspect of their job, talking to each other. I'm done. We have lots more information about this stuff. And that's my favorite site. The gang of people that I work with in Canada are called Crest BD, and we have a self-management website, which is beautifully put together in lovely language with nice videos, evidence-based content, and it's called the Bipolar Wellness Centre. And I encourage you to visit if you found this sort of chat at all interesting. Happy World Bipolar Day, and I'll hope to see you face to face in some other situation.